very reasonable approach to repairing small or moderate-sized ventral incisional hernias at the time of bariatric surgery. The problem with looking at the data, though, is that there is very little comparison with a primary repair at the time versus observation. So there's very little data out there that looks at them in comparison, and most of the data that's out there is looking at small or moderate-sized hernias. What about large incisional hernias? And these are typically defined as hernias that are greater than 10 centimeters or 100 centimeters squared in surface area. And this is a systematic review looking at 55 patients, almost 55 studies, almost 4,000 patients with large incisional hernias. And this is not necessarily just in the obese group. This is just looking at large incisional hernias. And what stands out in this table, there's a significant increase in wound complications, and there's a significant incidence of recurrence. And this is looking at open techniques, laparoscopic techniques, and component separation techniques. And so what we're really talking about, large incisional hernias are these types of giant, large incisional hernias with a fascial defect greater than 10 centimeters. And when you look at this, there are issues of incarcerated content, not only momentum, but also the small bowel. And when we talk about patients in this subgroup and ask the question, should we undergo synchronous repair of their hernia, there are several issues that you have to really consider. One is the perioperative impact, loss of domain issue, the integrity of the repair, and cosmetic outcome. And I'm just going to go through those quickly. If you look at the perioperative impact, there's no question there's increased pain, decreased mobility from the hernia itself. And this increases the risk of pulmonary complications as well as DVT. There's also the condition of impaired nutritional status around the time of surgery, which could significantly impact the patient healing and recovery and the integrity of the repair, as well as potential perioperative complications. If you put a large sheet of mesh in these patients, if you should have to go back for a bleeding complication or for a leak, this is a disaster in this setting. The loss of domain is particularly a significant issue. Typically, when these hernias are repaired, because of the loss of domain, there are maneuvers to gain more space in the abdomen, including omentectomy. Some surgeons have even done partial colectomies as well as debulking of fat. But most of these efforts still leave the surgeon with having to use a bridging technique where the primary fascia cannot be closed. So one of the techniques that Dr. Maneri talked about was the component separation technique. And this is where you gain basically hernial wall length by separating the external oblique fascia and also separating the internal sheath of the rectus abdominal muscles. And you can get almost 15 centimeters in terms of closure. And the idea is to bring the tissues back together. And this is what a component separation technique looks like. You see the big open fascial defect, but this can be closed primarily, and then a mesh is laid on top of it as an overlay repair. And typically, when this is done after a bariatric procedure, typically a year or 18 months after, there's a lot of excess skin. And so the patient gets the added benefit of a very nice repair. They're usually in a better state of health. There's a lot less tension, so the integrity of the repair is much better. And typically the patients are extremely happy because more than the hernia, they're really pleased with the cosmetic outcomes. So in summary, I think for smaller ventral hernias, the limited data out there supports that simultaneous repair is reasonable. Even mesh can be used because the mesh infection is really not an issue and recurrence rates are low. But when you talk about large ventral hernias, there's really no data to support a simultaneous repair. And the factors that argue for weight include the perioperative impact of the repair, the loss of domain issues, the underlying health of the patient, and the overall outcome in terms of significantly decreased recurrence rates and improved cosmetic outcome. Now, the one last point I want to make, and this is something that Dr. Maneri drove home, is you cannot leave a fascial defect uncovered. So if you have a patient with a large ventral hernia, I would really encourage you to consider the decision of the surgery you make. Because in patients with a large ventral hernia, I tend to do a sleeve gastrectomy because you can stay above the hernia, you can perform the procedure, leave all the incarcerate contents intact. And I think this is a reasonable option, particularly if the sleeve gastrectomy fails in the long run. I think there are very nice salvage operations that can be done simultaneously with a concurrent hernia repair when the patient is in a much better condition. Thank you.
Okay, we have the time for one question. No questions. Dr. Hampton is ready, Ahmad. He can join us.
Can you hear us? Just 1 minute.
I don't know if it's hear me.
We can hear you now perfectly. Can you see the slides?
I can, perfect, thank you.
Okay, great.
Does it sound all right?
Yeah, it sounds good.
Alright, so can I start? So,
Just a second. And try now.
so there's been reports there hernia bariatric also the hernia.
Sound is cutting off. Let's do it the classic way. We'll have Dr. Higa present first, and then we'll go to.
Okay. Okay, now Dr. Higa will talk about closing the hernia defect in anticolic versus retrocolic bypass.
Okay, so I guess this is not really a debate, this is a lecture. I asked Dr. Bishop, why isn't this a debate? He said because everybody closes defects now anyway, so I guess it's not that controversial anymore. No. How many people do an anti-colic bypass? How many do retrocolic bypass? How many people do both? Nobody goes retrocolic. Alright. Okay, we'll talk about a few things. So, anticolic or retrocolic should close the defects. How many people believe that you don't need to close the defects? Okay. Well, let's talk about whether or not we should go anti or retro, why we should close the defects. Now, for myself, I close the defects, I go anti, and I go retro, and there's a couple of reasons why. And I'll tell you why it's important. So, between the anti and retro, we're not on. Wait a second. I can see it. What's going on here? Can we switch? Excuse me. Can we switch to 3?
I see people, please.
Not only a great surgeon, a great IT person. Okay. All right, so certainly there's 2 hernia defects, anti and 3 in the retro. And the retrocog space can be difficult to find, I understand that, but really it's only for amateurs, because if you know this space, it's very easy to find. And what's important, especially when you have patients of a lot of pelvic adhesions, when you go supramesocolic to the anterior mesocolon, you don't have to mobilize that big giant momentum, and it can save your life many times. There are less interning hernias. Really depends on who you believe. I think there's data to show that if you close the defects in a retrocolic bypass, you're still going to have the same number of internal hernias as you do anticolic. It's faster, not really. Well, you don't have to mobilize momentum, and I think this is a big bonus because a lot of the larger patients, especially the male patients, their momentum is very heavy, you don't have to split it, and it can actually save you time. There's no mental infarction because when you go anti, you split the momentum, there sometimes you come back, and if you don't do it just right, some of the momentum will infarct, you'll have to come back. And there's certainly less tension, there's no question about this. Now, whether that will lead to increased leaks, decreased stenosis, depends on who you believe. I personally don't think that I see in the literature where it actually leads to increased stenosis if you go anti-retrocolic. The bottom line is I think you need to do both, and that's what we teach in our program. We go both ways because there are advantages from one or the other, and I really think you have to be fast with both methods. Typical story, this is a 45-year-old woman, 8 years post-bypass, loss of pulse for 7 years, 1-year history of abdominal pain. Was seen in 4 different emergency rooms, and CAT scans are done 4 different times because that's what they do in the emergency room. They get CAT scans anytime someone with abdominal pain, and they're all negative, except when you review the CAT scans, they're not negative. There's an airflow level in the gastric remnant. The patient was admitted to another hospital. The general surgeon was consulted. The patient had a small bowel obstruction, so the general surgeon said what most general surgeons would say: put an NG tube, and I'll see you in the morning. The patient then has it. Crashes overnight becomes acutely ischemic, tachycardic, hypotensive, goes to surgery, and then I get a call. The bowel is twisted, what should I do? I said, well, start at one end and pull. He said, well, now it's getting worse. I'm going to have to cut the bowel to fix this. And I said, well, just go the other way. And so when we close the defects, and this is a problem with the gastric bypass, and although we haven't seen it with the loop gastric bypass or the single natural bypass, I think it still exists. And these patients, although rare, can lose their entire small bowel, might be part of the colon, and this becomes a major disaster. We have to be on high alert for these patients, and we have to answer the call when our colleagues call from the emergency room about these patients, so that we are there to take care, because there is nobody who's going to take better care of that patient than the surgeon who did the first operation. So should we close the defects? There are a lot of literature that says yes, and there's some literature that says no, you don't need to. The most vocal is, of course, Raul Rosenthal out of Cleveland Clinic. Let's talk about the location. This is Harvey Sugarman's data. We see it in the mesocolon, the jejunal the Peterson space. These are all potential defects. This is our data that we published of the different things. You can see why, and I think this is a phenomenon of laparoscopic surgery. We saw this in open surgery as well, and the earliest descriptions of this was from the transplant literature. But we've seen this in open operations as well, just to a much lesser degree. But when we went to closing our defects from not closing or closing with non-absorbable material, we went from an internal hernia rate of 10.2 to 0.3%. Our current internal hernia rate is less than 1%, whether we go anti-colic or retrocolic. This is what the graph looks like. So we started our laparoscopic program in 1998. We closed our defects with interrupted absorbable suture, and we quickly saw a lot of internal hernias. We changed around here. By that time, we had close to 1,000 patients done wrong. As soon as we made this change, they're still turning out. And we still see patients from 10, 12 years ago with internal hernias. And we still see patients we do today. This author came up with a very novel idea. Well, if there's less adhesion from laparoscopy, let's just rough it up a bit like open surgery. So let's take a rate tape and rough it up and create adhesion. And they reduce your internal hernia rate from 5.3 to 1.4. Not statistically significant, but certainly a trend. So the bottom line, we can't really prevent internal hernias. It's really a phenomenon of minimally invasive surgery. But early recognition and intervention can prevent valve infarction. Now, the important part of our study is when we review in retrospect our CT scans and upper GI series, 20% of the time they were wrong. So you had a negative 20%, a false negative rate. So you can't rely upon studies. Anytime someone comes in with unexplained abdominal pain, they have to go to the OR or exploratory laparoscopy. It's as simple as that. To do any less is malpractice, in my opinion. A wait and watch phenomenon, I think, is definitely wrong, and you should close all defects when possible. Now, closing defects is not the end of the story either. So if you close defects and you do it circumferentially as I used to with permanent suture, sometimes that suture will erode to the inside of the valve. Here's the colon, the transverse colon. Here is the retrocolic rulin. And this patient has a lot of inflammation and pain, and endoscopically has a suture bezoar. So the suture has partially gone inside the valve, but we couldn't remove it endoscopically. So now we have to make an enterotomy, pull it out, and get rid of this inflammation. So you can see the sutures is partially gone in, became a nidus for trapping food, and then we have to close this thing. This doesn't happen very often, especially if you use a non-continuous suture from one end. In this case, I was using continuous circumferential sutures, and the incidence of this was very high. Now this author is very interesting. Looking at cadaver studies and trying to make the bowels line up in a certain way so that you don't have to close the mesentery. Now their hernia rate with 305 patients with follow-up of nearly 35 months on average was 0.3%. However, if you look at this article, 3 of those patients presented with pain and negative upper GI, so they were never explored. I suspect that those patients probably had internal hernias. If so, their internal hernia rate went up to 1.3%. So although their conclusion was it's not essential to close these things, I argue against it. Let's talk about expert opinion. So I asked Raul Rosenthal, because he's been a proponent for not closing these spaces, what do you do if you did a laparoscopy and find an internal hernia, you close it? His answer, and this is a text message, so I'll just, ha, you tricky pig. Yes. Depending on how big and how far out, most of my patients that I re-laparoscope for other reasons of bariatric operation has defects that close spontaneously. You can publish, love you. I think one of the most compelling arguments I have for closing internal hernias is this one. Now this obviously is a patient who's had some pain, has an internal hernia. This patient is pregnant. Second trimester of pregnancy.